There we go. Hey, good morning. Hello, everyone. My name is Rachel Wells. I'm a palliative care nurse scientist at the University of Alabama at Birmingham. I'm the and beyond in the title of this conference. So clearly not Appalachia. Um, I'm also the daughter of parents who live in Pickens County, Alabama. It's a county that's served by one primary care clinician. It doesn't have a critical access hospital or an urgent care. It's a county that is 2 hours away from the closest hospital that could provide stroke or MI intervention. And it's a county with one ambulance, which half the year goes unfunded. So much so that when my grandfather had a medical emergency, ooh, things disappeared. Um, I actually took him to the ER, the local ER that was 2 hours away, in my car because there was no ambulance because that ambulance was actually taking somebody else to a hospital. So needless to say, ruralness certainly is what I grew up with. I'm also the sister. Uh-oh, slides are fun today. Okay, how about we do this? Yeah, so I'm a sister of a sibling who had multiple congenital heart defects and has a hypoplastic left lung, who had multiple open heart surgeries by the time she finished elementary school, and who grew up alongside me all over the eastern panhandle of West Virginia. So shout out West Virginia, where we regularly rode hours into Virginia and Maryland and so many other states to get her specialty pediatric cardiovascular care. And so I made it my mission to improve access and transform care in communities that look like mine. And so while my story began in 1983, because again, I'm an elder millennial, the story that brought me here with fellow telehealth champions, which is the Enable model, actually began in 1998 with a version of the following story that happened over and over and over again at Dartmouth Hitchcock Medical Center. And so Mrs. Hensley stayed in this room. She was 74 years old. She lived in a small town in eastern Vermont. She had advanced lung cancer, and she had Mets to her bones. She had a landline phone and a daughter who was trying to hold it together. And her oncologist was more than 2 hours away. And she had never seen or heard of palliative care before. And so when the palliative care team first spoke to her in the ICU, after she was transferred by ambulance, she said something that they would never forget, which is, "I don't want to be here. It's the third time I've been here in 4 months, and I spend more time getting here and being here than I do living. And I don't know why this is happening to me, and I am tired. I'm tired of the pain. I'm tired of the nausea." And then she lowered her voice and just whispered, "I wish somebody could help me make sense of this." And so it started with a few people who thought they could maybe help her make sense of that, and that they thought they could make palliative care more accessible. And that's Dr. Marie Bacchitis, who was then at the time a palliative care NP at Dartmouth, and then a few others who came together to develop the Educate, Nurture, Advise Before Life Ends, or Enable, because I won't say that again, Enable intervention. And so really that's what this talk is about, or the story is about. It's about what it means to be seen, to be supported, and to be cared for, no matter where you live and no matter what you're facing. And so I am a researcher, please forgive me. I'm gonna have occasional slides like this. So all across rural America, millions of people face serious illness, and many do it without access to comprehensive, high-quality palliative care. And that's really despite the fact that evidence-based guidelines, whether it's from the World Health Organization, or the American Cancer Society, or the American Heart Association, or pretty much any professional organization around serious illness, all recommend that we provide early palliative care at the point of diagnosis of advanced illness. So we know we're supposed to be doing this, and we know we're supposed to be doing this because it improves outcomes. But too often, that nearest cancer center or cardiologist or other specialist is hours away, and palliative care, that's considered a luxury. If it shows up at all, it shows up late, when patients and families are already overwhelmed. And when it does show up, it often shows up as hospice, which is a whole other talk some other time. If you want to talk about palliative care as a continuum, I'm super passionate about that. But in fact, in 2015, when we looked, we tracked it, how long it took for people to get palliative care. It took 110 days. from the point that significant symptoms or pain showed up in a patient's chart until palliative care was consulted. And that was on an inpatient side. So that's just presupposing that you could actually get to a academic medical center where palliative care really was. And then when they were consulted, it was often close to death. In fact, on an average, 3 days before a patient died. So we weren't really doing our job there. And that was mostly urban patients. When we looked at rural patients that were actually showing up in the system, they had even worse timing. And so we certainly didn't have the palliative care manpower and presence in rural spaces in 1998 for Mrs. Hensley. And we didn't have it across the rural South, which is where I was a cardiac ICU nurse in the 2000s and 2010s. And so one of the reasons why, again, forgive the researcher me, that I have these charts is because I just wanted to show the progression of where we were as far as palliative care access in the US. So every 2 years, CAPC comes out with state report cards on palliative care access. So prior to 2015, less than 10% of all palliative care programs were in a rural area. It got moderately better in 2015. And 2015 was actually when they first started to track not only what palliative care and inpatient, but outpatient palliative care in across rural and urban spaces. And then if you look at 2024, we're still not great. So the idea, the lighter the color, the worse you are. So especially kind of you look on the eastern seaboard, up northern eastern seaboard, it's pretty good. But as you get further and further south and further into the middle of the US, we still have quite a way to go. And rural Americans really deserve more than heroic rescue in those final hours, and they deserve connection. And so again, this is my last slide. I apologize, researcher. So this is really where Enable comes in. You know, it began in rural New Hampshire and Vermont, and over time it grew as a tested, evidence-based approach that helps patients and their family caregivers live better lives, not just longer lives. And so now it's across the US and tailored for advanced cancer, which is the one that's on the left. That's all the tailoring for cancer. And then also advanced heart failure with and without a mechanical circulatory assist device, advanced COPD, and chronic kidney disease. And it's been rigorously tested through multiple randomized clinical trials, and the results are clear. Patients reported better quality of life, better mood, better symptom control. They had less depression, they had less anxiety, and they had fewer hospitalizations, which is a really key point because when you're trying to make a case for billables, for some sort of financial success or billable services, looking at hospitalizations is a really important marker for health systems. When we tested with Enable 3, looking at early versus a little bit later introduction to early palliative care, it showed that the earlier you introduce palliative care, the stronger the outcomes are. So it works. It works not just for patients, it works for families too. And so I really delivered the storyline before the entire story, which the takeaway is that the Enable, which is a coach-led early palliative care telehealth model, is flexible. It's robust enough to not only meet patients where they are and their families where they are and living with serious illness, but also meet clinicians, clinics, health systems, and payers where they are, because we have done it in pretty much every potential setting that you can possibly imagine and adapted it along the way. So what do you need, and what exactly is Enable? So you need 3 things. You need somebody who will act as a palliative care coach. They get about 40 hours of palliative care specific training. You need some sort of telephone or video conferencing access plus a guidebook of sorts. And you need a single palliative care clinician. And so when we brought Enable down from Vermont and New Hampshire all throughout the eastern US, we had to adapt. Video, telehealth, and in-person wasn't always feasible. And so we started to use a telephone. So I love the idea about the telephone. It is something that really worked well. And for a lot of our, and I'll speak a lot about Alabama because that's where I live, a lot of our communities in Alabama do not have broadband access. In fact, if I go see my parents in Pickens County, I have to go up a hill and stand like on my 1 foot to get my cell phone access because the access is so poor out there. And at first we partnered and trained local advanced practice nurses. And then we're like, okay, well, really, is the content we're delivering within the scope of practice of an RN, a registered nurse? And it really was. So then we partnered and trained local registered nurses. And now we're partnering and training lay navigators. So we're tying into navigation and community health worker systems that are already in place and training them with palliative care content to deliver this intervention. We partnered with communities. So again, hearing this concept over and over again is really knowing your community and partnering with them to refine and tailor in a culturally responsive manner the guidebooks, the scripting, and how we even approach people to be part of the Enable program. We did that in order to build trust, in order to scale up. And people responded. What started as a pilot became a lifeline for families across rural Vermont, Tennessee, Alabama, Florida, Colorado, California, and kind of pretty much anywhere else, because now we have the training widely available across spaces. And of course, we faced barriers because many areas, like I said, did not have broadband internet access. Patients were really hesitant to use technology, which is why I love the idea of having a digital shepherd. And then others have often said, or always said, like, what is palliative care? I've never heard of this. And they didn't trust what they didn't understand. And so the lesson that we've learned over the last 20 years is that all of these barriers are barriers that can be overcome. Whether it's using phone coaching instead of video or in-person coaching, it's using local champions to introduce the program. We didn't try to force a model when we did Enable. We bent Enable towards what rural communities needed. And so what is actually Enable itself? Because I talked a lot about it. It is kind of a three-part system. It is a single, or at the first, we sell it as a single outpatient palliative care visit. And that visit can be in whatever the modality that is preferred by the individual. So we offer inpatient when we stack it with other specialty clinic visits if they're coming to see their oncologist. It could be that we are delivering it using a video conferencing platform. In Alabama, we use our AHECs, our public health centers, which has all of the telehealth platform available to them. So they just travel to that because it's within that magic 90-minute away window. Or we have done it by phone as well, because it's just whatever is preferred by that individual. And then we have their palliative care coach. And this is kind of the magic that's in the sauce. Their palliative care coach, which now I'm training navigators to do this, deliver between 3 to 9 sessions. In general, these sessions cover content like problem solving and coping, symptom management for whatever the specific disease modality is, self-care strategies, healthcare communication and decision-making. And then if you're a patient and not a family caregiver, it also covers life review and legacy building. So kind of core palliative care content. And then we also instituted monthly check-ins. It can be one single check-in. It can be following them over a period of time. So it's flexible enough that according to what your infrastructure and needs and the willingness of a clinic or a health system to support it, you kind of meet your patients where they are, but you're also meeting the health system or the clinic where it is. Enable is coach-centric. So one of the things that we learned over and over again, culture and trust matter. We heard people don't just want a clinician or a provider, they want a relationship. They want someone who listens without judgment, who explains without rushing, and who respects their values. And the Enable coaches often became that trusted voice. They gave not just information, but they held space. And that's where the magic happened, not only in what we prescribe, but in how we show up. So when faced with challenges, we often tried to keep, because I say we, it's a very large collective of investigators and clinicians that pretty much now track over the entirety of the US. We try to keep in mind the quote, which is transformation rarely happens accidentally. And even when it's uncomfortable, transformation always leads to new beginnings and better outcomes. So some of the operational challenges we had is that there's always going to be training and turnover. So you do expend a certain amount of time training a coach up. And when you have turnover, it can get really frustrating. So we have focused on how can we retain coaches, particularly when they're community-based lay navigator coaches. We had no-shows. I love that question because I do actually track it. I track the palliative care consult when if they show up, if it's in person more likely versus if that is done via video conferencing. And by the way, I do have the data overwhelmingly. So our no-show rate for in-person palliative care consultations is about 50%, which is actually it's a national standard around that. For ones when we offer them either using video conferencing platform or telephone, it's 30%. So it's a pretty substantial drop. In fact, I'm presenting data on that in October. So the other challenges that we had is that we've heard people say, I'm not a phone person or I'm not a video conferencing person. And so finding ways to kind of provide a hybrid has been important. So we would have one in-person community-based visit from the navigator who lives in their community, who knows their community. And then we kind of built rapport and went from there. And then literacy, both digital literacy, but also reading literacy. And it's a huge issue in Alabama. 1 in every 3 adults is functionally illiterate. And then we had issues around timing and triggers. Like, how do we decide when is it too early to initiate this? Is that something that we can do across all diseases, or is it disease specific? And then really the importance of having primary care clinicians buy-in. So, because they are really the hub for so many of our rural patients, is that they are a valued person in the community. They respect their decisions and respect kind of their thoughts around involvement with palliative care. So we've learned to really partner well with our primary care clinicians in the community. The other thing is, again, we need champions. Like, whether it was a telehealth champion or it's a health system or a clinic or it's a community-based champion, tailoring is really important. So taking the time to realize that West Virginia, while they share attributes with Alabama, they're not always the same on all things. And so taking the time to really work with the community. Caregivers need individual attention. So originally this was an intervention that was dyadic. Both the caregiver and the patient got the intervention at the same time. Now we have completely separate coaches for caregivers. Finding funding for that is really difficult, but I have some thoughts. Again, because you tie it to patient outcomes like reduced hospitalization, reduced complexity of care towards end of life. And then again, the concerns around establishing rapport and assessments via phone was really unfounded. And it's been a journey. So let's go back to Mrs. Hensley. This is Mrs. Hensley, not really, but a representation, and her daughter. So again, Enable's not just for patients. So it's for the people who walk besides them. And so her daughter, she got 4 sessions with an Enable coach. And they told us as a caregiver that they felt less overwhelmed, that they felt less depressed and more confident in their ability to meet their patients' needs or their loved ones' needs where they were. And this is a literal quote from one of our things, which is, before Enable, I felt like I was drowning. And after Enable, I still had rough days, but I had a life raft. So it teaches caregivers how to cope, how to care, and how to find peace kind of in midst of all of it. And so for Mrs. Hensley, one of her early calls with the nurse coach that she had, she said, I just want to be able to sit on my porch this fall and watch the leaves turn and then feel the breeze. And so that really became her goal of care as she continued her cancer treatment for a while, but she only continued if it meant that she did not have another ambulance ride away from her porch. And with that, I'll end it.